We're very happy that you're joining us for the presentation by Lynette Wilson, who is a retired nurse practitioner, and our topic today is managing inevitable emergency room visits and hospitalizations.
Okay, I think the first question that many people may have as they think about this and look at it is, why are we even talking about this topic? I want to start out by giving you some information about why this is an important topic, and in the form of several sets of statistics. For those of you who haven't heard me before, I like statistics. I like numbers because I think they carry a weight in many circumstances that if someone just says, well, I know this is better or this is worse, is not quite the same. So let's talk about what happens with people with dementia. A person living with dementia is twice as likely to seek emergency room care and be admitted to the hospital as a person who does not have dementia. And at least one large study that I read has shown that in the 6 months prior to a dementia diagnosis and the 6 months after that initial diagnosis, there is a 40% increase in emergency room visits for those people with dementia. At least 85% of the people with dementia have one or more other chronic conditions, and many have as many as 5 or 6 chronic conditions that are not related to the dementia itself. These conditions continue to need to be monitored and usually treated after the dementia diagnosis and may cause problems at various points in time. So based on that, the chances are pretty strong that your loved one at some point in the journey will visit the emergency room or need to be hospitalized. It helps then to be prepared because emergency room visits and hospitalizations can cause significant problems for people living with dementia. In general, about 75% of individuals with dementia who are 75 years of age or older and functionally independent at the time of admission to the hospital are not functionally independent when they are discharged. To say that another way, 1 in 4 people, or about 25%, are discharged at the same functional level at which they entered a hospital. About 2 in 4, or 50% of people, have a functional decline of at least 1 level and require additional support services after discharge from the hospital. And another 1 in 4, or about 25%, have a more significant functional decline and die within 3 to 6 months of a major hospitalization. As we talk about this topic today, though, I also want you to keep in mind that in the United States, estimates are that somewhere between 20 and 40% of hospitalizations are preventable. In stressful situations, you who are the caregivers are typically the ones who decide when a person needs to go to the emergency room as opposed to being managed at home. So this is something that you have some control over as a caregiver. Why are dementia patients seen at hospitals? The major reasons to be seen in the emergency room are accidents resulting in injuries, falls, behavioral or mental health crises, general weakness or functional decline, and the need to manage some kind of comorbid or coexisting medical condition or an infection. The major reasons for hospitalization overlap that quite a bit, but are infections, falls or injuries from falls, cardiovascular or pulmonary issues, again, typically from those previously or coexisting conditions, and dehydration. If you think about what you know about dementia and your own personal experience thus far with dementia, you can easily see why these are the top reasons for hospital visits. So what causes problems when you're in the hospital or in the emergency room? Several different things. The first is unfamiliar surroundings, people, procedures, and routines. Most of you know that the person living with dementia gets out of sorts and has a lot of difficulty coping many times when there's a significant change in their routine. So let's talk about this. When we talk about problem, let's talk specifically about the emergency room and what happens, because almost all hospital admissions at this point in time are through the emergency room. So imagine yourself being on a stretcher, perhaps strapped down if you were brought in by EMS and were at all combative or agitated during the process of transportation. People you don't know are talking to you, and you don't understand what they're trying to say or what they're asking you. Then someone wraps a blood pressure cuff around your arm and squeezes your arm. Somebody puts a tourniquet on an arm and you're stuck for an IV. And all of this happens while you're in a strange place. Add to that lots of lights and loud noise. And many of us without dementia would be confused and agitated at this point in time. Then add to all of that the amount of time you're subjected to this difficult situation. As we all know, emergency room visits have become notoriously long, many lasting up to 20 plus hours. One reason this happens in older adults is that they're presenting problems, or at least what we can figure out they are, is often different from presenting problems for a younger person. For example, a younger person who complains of chest pain and pressure, you're going to think immediately heart attack and start looking at that as a diagnosis. For an older adult, they may have nausea. They may just have a feeling of indigestion. They're more vague symptoms typically. Research has shown that somewhere between 20 and 50% of all physical presentations in older adults are atypical in terms of the symptoms that show up. For this and for many other reasons, the average time a person living with dementia spends in the emergency room as compared to a person without dementia is a little more than 3 hours longer. So you've got that long ER visit that's typical, and add to that even more hours for a person who has dementia. And if that person is admitted to the hospital, the difference increases to more than 4 hours longer. Longer emergency room stays are themselves associated with increased risk for death, delirium, and medication errors. In addition to these two things, especially in the emergency room, there are typically new medications that are added. More than 50% of people living with dementia will get a new medication added, at least one, if they have an emergency room visit. And more frequently, that will be several different medications. As you might remember from our discussions about medications and dementia, one of the rules is one medication at a time, start low, and go slow. So this is going to violate every rule that we have for dementia and medication administration. They may get medications, or they're likely to get medications for agitation because of all of the preceding things that we've talked about. And then the last thing is, unfortunately, there are too many hospital staff of doctors, nurses, aides, everyone in the hospital who are still unfamiliar with dementia and how to take care of a person with dementia. We have to remember that hospitals are built on routine and adherence to procedures, and that when one goes to the emergency room, the focus is on the presenting problem. Why did I come here to start with, not what all else is going on in my life? And sometimes that presenting problem is very narrow and no one is even asking about dementia or what's going on with that. And then unfortunately, especially since COVID, hospital staffing levels are still not back to the levels they were before. So we're talking about a number of issues with staff that make the process of going to the emergency room more treacherous, if you will, and difficult for a person with dementia. There are also problems that can arise during a hospital visit that are new problems. One is falls and fall-related injuries. The person who comes in with dementia is already weak from whatever caused them to come to the emergency room to start with. They're often confused, and again, they're in an unfamiliar bed in an unfamiliar room. They may be given the call bell, but they don't remember where it is or how to use it. They're more likely to use a walker or some kind of aid for ambulation. And in general, the fall risk in elderly persons with dementia who have an abnormal gait and balance problems is 3 times greater than for elderly persons with dementia who have a normal gait. And they're more likely to have urinary incontinence and vision problems, so they may try to get up and go to the bathroom unassisted and fall easily because of that. People in the emergency room can get skin tears and breakdown, although these tend to be more prevalent when somebody's hospitalized. Think about how fragile the skin of the person who has dementia that you're taking care of is. I don't have dementia that I'm willing to admit, and yet when I bump my skin, I get bruises, and in people as they get older, the skin is thinner and tears more easily, and that skin breakdown causes an increased risk for infection, immobility, and pain. Untreated pain. There was a 2000 study reported in the Journal of the American Medical Association that compared the number of procedures patients had and pain relief if they were admitted to the hospital for a hip fracture. Those with dementia had the same number of procedures as those who didn't have dementia, but received 1/4 the amount of pain medication and 3 times the number of antipsychotics. So treated very differently. Of the antipsychotics given, Haldol was the #1 administered. And as you may know, Haldol is not a good thing for somebody with dementia. And particularly if you have Lewy body dementia in the picture, Haldol is absolutely contraindicated. It is the #1 medication given in most emergency rooms for any kind of agitation, though. We've talked already about functional decline and increased risk of death in emergency rooms. The other problem that's caused, that can occur during the emergency room and may be the reason one ends up in the emergency room or the result of being there, is something called delirium. And delirium is really important for us to know about, so I'm going to spend a few minutes talking about delirium itself. Delirium is a state of worse than usual mental confusion brought on by some type of unusual stress on the body or the mind. Dr. Leslie Kernisan, who has a blog about aging on the internet, describes delirium this way, and this is a quote: "Delirium is basically a reflection of the brain going haywire when it gets overloaded by the stress of illness or toxins. It can happen to anyone, although it's very rare to happen in younger people. It's usually triggered by medical illness or by stress, particularly the stress of hospitalization, if that hospitalization includes surgery and anesthesia." Since the brain of the person living with dementia is already compromised and more vulnerable, delirium can also be caused by medication side effects and by less severe illnesses and by those environmental factors we talked about in the emergency room. Delirium develops over a short period of time, usually hours or days. You may hear somebody say, man, all of a sudden their dementia got so much worse. They're so much more confused. They're more agitated. I don't know exactly what's going on, but it's like the dementia really took off in severity. In most instances, that means there's some kind of delirium going on. Usually dementia causes a slow decrease in abilities over time. And again, we're talking about delirium that changes where changes occur in a couple of hours or a couple of days. The key symptom in delirium is difficulty focusing or paying attention, but you may also see memory problems, language problems, confusion, hallucinations, and perhaps paranoia. We often think of delirium as causing agitation or increased activity, and it can in fact cause that. It can also cause a decrease in activity level, and this is called hypoactive delirium. A person with hypoactive delirium may be withdrawn, lethargic or tired, drowsy, unusually sleepy, or unable to stay focused when they're awake. And it's also possible for behavior to alternate between increased activity and decreased activity. It's critical to identify and treat the underlying cause of delirium quickly, because it is, as I said, a sign of something going on with the mind or body that's causing problems. And because the confused person is at higher risk for falls and injuries. In addition, delirium often causes serious consequences such as increased hospital stay, higher chance of dying while in the hospital, a decline in independence in the long run, and it can cause an acceleration of cognitive decline even long after the delirium has passed. Delirium is associated with poor outcomes, including death. Roughly half of patients who develop a significant delirium die within 6 months. Delirium may also hasten cognitive decline. One study found that the rate of cognitive deterioration up to 5 years after hospitalization that included delirium was roughly twice the rate of a person living with dementia who did not experience delirium. The longer delirium lasts, the poorer the outcome, but again, it may be reversed if it's identified earlier. Delirium is more common in persons with Lewy body dementia, but it's particularly difficult to identify in these individuals because the symptoms of LBD itself overlap with the symptoms of delirium. In this case, it's even more critical than usual for a caregiver to be available and to be tuned into what differences they are seeing in the person with dementia and be able to relay those specifics to medical personnel. What causes delirium? Pain, infection, constipation or retaining urine, inability to empty the bladder, dehydration, low blood oxygen, poor nutrition, as I said before, a change in medication, metabolic changes such as low blood sugar or high blood sugar, electrolyte changes such as low levels of sodium or calcium. Lower levels of electrolytes are much more common than high levels. And as I've said already, unfamiliar or disorienting environments. So I think it's easy to see by this time that visits to the hospital may start or perpetuate a vicious cycle where if it's extremely difficult, if not impossible, to figure out what's causing what and where to start in correcting the problem. So knowing all that, what does a caregiver do? Many of the things a caregiver can do to minimize the impact of hospital visits begin well before there's any indication that such a visit might occur. Number one on the list is take care of yourself. That sounds really counterintuitive when what we're talking about is the person with dementia having some kind of acute problem going on. However, remember what I said at the very beginning. Caregivers are the ones who usually make the decision of whether to go to the emergency room to start with. So you have to have the capacity to think clearly, make clear decisions, and to report in detail what you see going on with your loved one, especially as it relates to those cognitive and behavioral changes. Recruit and educate team members to help with information gathering and decisions. Remember that dementia caregiving is a team sport. It is not a solo activity. You need to have at least one member of your team that you can depend on to show up for you at any time of the day or night, who understands your priorities and who can help you think through decisions and listen to information that's being provided from medical personnel. One example of when I took advantage of this was when my husband had the heart attack that he eventually died from. I knew there was not anything we were going to be able to do, and he was in an assisted living facility. Of course, the first thing the facility wanted to do was call EMS because he's having chest pain. And I'm going, no, I don't want to go to the hospital. He doesn't want anything, didn't want anything done anyway. We're not going anywhere. Well, they called EMS anyway, but I'm still going, no, we're not going to the hospital. But there was this problem with controlling pain. I had called my younger daughter, who's also a nurse, and when she got there, she looked at me and said, Mom, we're going to the emergency room. That is the only place that they can give him adequate medicine to control his pain now. Yeah, she was right. I was so focused on avoiding the hospital that at that point in time, under that unexpected stress, I wasn't able to think as clearly as I should be. Although I knew that pain control was what I wanted, I was not able to think through the options and know that going to the emergency room really was the only option available for adequate pain control for him at that point in time. Decide what's important in terms of quality of life and length of life for the person with dementia at this point in time in the dementia process. What's important changes many times during a dementia journey. And so we must constantly reevaluate, given where we are in this process right now, what does quality look like? And what am I willing to trade perhaps for length of life as a trade-off for having more quality in a person's life? Think about what makes sense for the person, not what it's possible to do. And many times medical staff are going to be talking with you about what's possible to do, not what might make the most sense for this person. Know this yourself and make sure you convey it to family, to other caregivers, and especially to that person who might be with you when you go to the emergency room. Discuss what to expect with this kind of dementia at this point in time with a primary medical provider or specialist. Talk with your loved one's primary care provider or whomever's providing dementia care about what to expect as things change with the dementia. Talk with medical care providers about how a comorbid condition impacts dementia and how dementia impacts that condition. Make sure that medical providers are aware of your goals of care. Is my emphasis on quality of life? Is my emphasis on length of life? Or do I want to balance between the two of those? Ask questions like, should I worry if he falls? What do I need to do if I think he has a urinary tract infection or some other kind of infection? Think about services from palliative care or hospice if the person is at a point where they qualify for hospice services. Having these services available puts a medically knowledgeable person who knows you and your loved one within easy reach 24 hours a day. Understand the pros and cons and any alternatives for recommended treatments. What do we hope to accomplish by having this treatment? Don't be afraid to ask questions and to ask for clarification of answers to make sure you understand. Always ask, what difference will this make for my loved one? And don't be afraid to opt for comfort care only. Another situation that I encountered with Roy was actually a couple years before he died. He was in assisted living and he had what we were sure was a stroke. He had had a previous fall when he was at home where he fell on concrete, fractured his skull in 3 places, bled into his brain. So I had that as history. Strokes are caused either by blood clots in the brain, in which case if a person gets to the hospital quickly enough, they can be given a clot buster and restore that blood flow, or they're caused by bleeding into the brain, in which case there's not a whole lot you can do but wait and see what happens. Since Roy had already had bleeding into the brain, I knew that he was not eligible to get clot busters, even if that's what was causing the stroke. And they were only going to watch bleeding anyway. So what was the point in going to the emergency room? So I opted to keep him in assisted living, stayed in his room with him for 4 or 5 days until things were relatively stable. So think about what your options are. Think about what's important and what difference would anything recommended make. Be able to describe what the person living with dementia is typically like and what differences you're seeing. You know that person better than anyone else. Be as specific as possible when you provide these descriptions. For example, is he sleeping 20 hours a day for the past couple of days when he was only sleeping 8 or 9 hours before? Has she stopped eating anything and is now only drinking a little bit of fluid a day? Does he moan and grimace even when he's just lying in the bed and nothing's happening? Is she pacing the floor for an hour or more at a time and trying to hit at anybody who even speaks to her? If you think pain is an issue, try Tylenol. Tylenol is recommended even for those people with Lewy body dementia as a frontline treatment for pain. Studies show that 60 to 80% of nursing home patients with dementia regularly experience pain. Think about yourself. As you get older, painful joints after you sit for a while or when you've been in bed for a while are more common, as are other areas of your body that frequently talk to you when you don't treat them real kindly. 1 in 3 residents of nursing homes experience moderate to severe pain and patients with more severe dementia experience more pain than those with less severe dementia. For most people, Tylenol is not contraindicated. I would check with the medical doctor about that, but it is a good place to start for pain management. Sometimes physical movement, if one's stiff, also helps with pain. Music, massage, heat, lidocaine patches are all helpful in some instances, and sometimes just human interaction and a calming presence are all that's needed to reduce pain. Be proactive if you think problems are developing. Know best how to contact the regular medical care providers or the medical care provider you depend on the most, especially if you need guidance urgently. If it's during the day, do you send a message on the patient portal? Do you call and go through the triage process at the office? What happens after hours? Some offices now have extended office hours on some days, and also have some office hours on weekends. Can a telemedicine visit accomplish what we need in this circumstance? Can I bring a urine by the office for somebody to see? Asking those questions ahead of time will give you more options for how to deal with a problem as it occurs. And then have medical information ready in case of emergencies. Make sure that you have a listing of current medications, including recent changes, any allergies, current diagnoses, a listing of medications that should not be given to this person, either because they have allergies or because they have Lewy body dementia, and there are some medications that are contraindicated. That you have insurance information and a photo ID, copies of any advance directives and healthcare power of attorney, and anything else that might be helpful to the staff so that they better understand this person living with dementia. The Lewy Body Dementia Association has online available this medical alert card that on the front of the card gives you just some basic identifying information about the person that has Lewy body. On the back, there's information about the emergency treatment of a psychosis in Lewy body, explaining what that might look like, talking about some of the things that should not happen and the medications that might be most appropriate to give. If Lewy body dementia is in your picture anywhere, I strongly encourage you to print and fill out this card and keep it with you at all times. There's also an article available on the Lewy Body Dementia Association website that talks about treatment of psychoses in the emergency room and is written for physicians. It's not a bad idea, again, if Lewy body dementia is in your picture, to print that article and have it with your emergency information that you have together. And there's some references for that will point you more on where to find these later in this presentation. Don't expect staff to have expertise in caring for persons with dementia. As we've talked about before, that's not, while it's more and more the case than it used to be, that's still not the case, and may be particularly true in emergency rooms because, again, they're dealing with presenting problems and not with the overall picture of what's going on with a patient. Try to make sure then that you or another member of your team stays with the person in the emergency room or the hospital at all times. Not only will that be more calming for them, but it allows you to advocate for them on an ongoing basis. Be prepared to help hospital staff or emergency room staff to understand dementia in general and the specific needs of your loved one, such things as what name the person would like to be called, what makes them agitated, what they respond best to. Control the environment as much as possible. Know what works best for keeping your loved one calm and ask to use it. Many times, lights can be turned down. If they're in the emergency room, the alarms on monitors that can be heard in the room can often be turned off because those alarms are also funneled to a central location for nursing staff to watch. You may be able to also ask for it to be warmer or cooler in the room, or for the door to be closed and there to be as few interruptions as possible. Know your rights and your hospital resources. I want to read a few paragraphs to you, or a few sentences to you from the UNC Hospital's Patient Bill of Rights. I think we've all heard about bills of rights, seen them enough, signed that we've gotten them, that a lot of times we don't even look at them anymore, pay attention to them. But I want you to listen to a few phrases from this Bill of Rights and think about how they apply to individuals with dementia. First of all, a patient has the right to be treated in a dignified and respectful manner. Again, you might have to advocate for what means dignified and respectful for your person, but keep in mind that they do have that right. Except as medically necessary, a person has the right to not be awakened, to be free from duplicate procedures, and to avoid treatments that cause discomfort. A patient has the right to effective communication that's understandable to them. Again, you are probably going to have to advocate for these things, but you may want to hang on to that patient bill of rights if you're in the emergency room of the hospital and highlight some of these things in case you need to point them out to staff, depending on what's going on at the time. Most hospitals have patient advocates or patient representatives that work with the family when there's an issue to help understand family concerns and help resolve these issues, and to clarify communication if that's needed. Hospitals also have ethics committees. These committees don't usually make decisions, but they can facilitate the discussion between parties, particularly making sure that each party is hearing what the other is saying. So if you have a disagreement with medical staff about what treatment is appropriate for your loved one, it may be that someone from an ethics committee would get involved in that to help facilitate that discussion. So a trip to the hospital may be unavoidable, as we learned early on, but our role as caregivers is to minimize the negative impact of that trip while advocating strongly for what is best for our loved one who's living with dementia. Here's a listing of resources about hospitalizations of people with dementia in general. And I'm going to flip through these because you can either take a picture of the screen, you can go back to it when Pat posts the video. Sometimes surgery is unavoidable. This is a listing of resources that might be helpful in preparing for surgery if that is unavoidable for your loved one. And whoops. And then this is the slide that shows you what is available that's particularly helpful at the Lewy Body Dementia Association website. Okay,